We're going to talk about ovarian and other adnexal cysts. And keeping also with the goal of bringing in other modalities to this Thursday general session, I hope to update you and review a little bit the role of MRI in the evaluation of cystic lesions in the adnexa. I have no relevant disclosures. Figures from radiology are reprinted here with permission. So my objectives for the next 20-25 minutes are that you, and this really is review, I know, for this type of audience, but make sure you understand the imaging appearance of the common and recognizable cystic masses in the adnexa. We're going to review the ultrasound features of cystic adnexal lesions that are benign, those that are indeterminate, and those that are highly worrisome for malignancy. And I want us to all learn again that MRI is used really mainly as a problem-solving tool in the setting of a sonographically indeterminate adnexal lesion. We all know that adnexal cysts or cystic lesions are common and they're very often benign. The prevalence is up to 18% in the general population. Vast majority are found to be benign. And when I say benign, that includes the normal physiologic cystic structures. The management of adnexal cystic lesions is based on both their imaging appearance, and that's where we come in, as well as the clinical picture, so in collaboration with the clinician who's caring for this patient. Pelvic ultrasound is, of course, the primary and certainly the preferred imaging modality to evaluate cystic lesions in the adnexa, especially at the start. So what's our role? Well, our role is, multiple things, but definitely to be able to confidently identify benign lesions. We don't want to pursue intervention when it's not necessary. Our other role is to confidently identify high-risk lesions, those that are suspected cancers, and get the patient to the right provider, which is gynecologic oncology, for those suspected malignant adnexal lesions. So what are we good at, and how do we deal with that gray zone? So ultrasound, of course, has very high specificity for the diagnosis of benign lesions in the female pelvis. That includes simple cysts, hemorrhagic cysts, endometriomas, and dermoids. So we're great at that. Ultrasound also has high specificity for the diagnosis of ovarian neoplasms with vascular solid tissue. Some of these very often are malignant. We're really good at that. So the white here is a lot of benign things. The black is that danger zone of the vascular, potentially malignant lesions. And then we've got our gray zone. And that's what's challenging. That's where MRI can be most helpful, and we'll get more into that as we move forward. The lesions that have indeterminate features are those with an avascular solid component. So something that really does look like tissue in a cystic lesion, but you really can't document any color flow on ultrasound. That could be an irregular thickened septation or septations, or an avascular nodule, possibly at the periphery of the lesion. Also in that sort of gray zone, but under a little bit of a different umbrella, and you know this from looking at these cases, is that those sometimes we see a cystic lesion that otherwise, really looks like a benign appearing hemorrhagic cyst, endometrioma, or teratoma, and you want to call it that, but it's either too large for really definitive ultrasound evaluation, or it has somewhat atypical features, and you don't feel comfortable just putting it in that box right off the bat. So this is what I consider the gray zone in those indeterminate regions, and this is in line with the SRU guidelines of what falls into an indeterminate lesion. What are our options when we find ourselves in the gray zone? Well, multiple. They range from things like ultrasound follow-up for something you think really is just an atypical appearing hemorrhagic cyst or a large hemorrhagic cyst. Sometimes patients need to go to surgical evaluation for an indeterminate lesion, and that may be swayed by their clinician, their menopausal status, their other risk factors. And then sometimes MRI has a real role in helping us work out what's worrisome and what's not. So I'm going to use the SRU guidelines that published in 2010 from the 2009 Consensus Conference as a framework to move forward in reviewing these lesions. I want to make sure to recognize that we'll be seeing updates in a lot of the subsections of these guidelines even this weekend. We'll be hearing more about it, and I'll allude to that a little bit. But here I'm using it as a framework, not specifically to get into the nitty-gritty of every table, although I'll show some tables, but because this framework works so well for us in our practices. I think what's important to remember about the guidelines is that it did include non-radiologists, both gynecologists and pathologists, which lends it more weight and validity. The guidelines here, really rely on pattern recognition, which has really been shown to be effective in the Adnexal. This is not templated feature reporting or scoring, although there's a role and certainly an emerging role for that, and we'll hear more about that this weekend as well. Here we're talking about pattern recognition. The SRU guidelines rely on knowing the patient's menopausal status, and of course whether the patient is pregnant or not. And these are guidelines that were developed to be applied to an asymptomatic patient, but certainly, as you all know in your practice, you're not going to abandon these guidelines because someone's symptomatic. We use the same pattern recognition, perhaps with some nuance to our interpretation in those who are symptomatic. And then, the guidelines lead us to one of four buckets in most cases. No follow-up benign, confident benign. That's a big, big part of our job. Ultrasound follow-up in some cases. There's a whole, category of indeterminate lesions, which we'll get into, which can either opt for a surgical evaluation or go on to MRI. A lot of that, the intention here was based on the fact that not every practice has the same availability, expertise for pelvic MRI. So there needs to be a little wiggle room there, and MRI is not mandated in every case, but is a great option, and I'll explain that more. And then some lesions, of course, we see, and they need surgical evaluation. There really isn't a role for any other workup. So like I said, stay tuned this week for some updates regarding the SRU guidelines, especially in the keynote address from Dr. Levine tomorrow about simple adnexal cysts. So here you are, you're sort of steering the car here when someone's there for an ultrasound, and you have to decide whether something's going to be left alone, see ultrasound follow-up, go to GYN or GYN-ONC, or whether MRI has a role somewhere in these pathways. So basically, we always start with the follicles and the simple cysts. I'm going to tell you, I'm using the word cyst here because you all know what that means. When I say cyst, you have something in your mind. You know what I'm talking about. I'm talking about an oval anechoic structure with a thin imperceptible wall and no color flow. I don't use the term cyst in my ultrasound reports if it's a follicle or something physiologic or that simple, and we'll get more to that. But these are exactly as you're imagining, as you know, thin, smooth walls, anechoic, usually small, and really are just benign, and especially in the patient of reproductive age, part of the normal structure and activity of the ovary. You certainly can see sometimes a thin septation, and we'll get to that, and the guidelines are going to be variable in the postmenopausal patient. This was published just this year, 2019, specifically on simple adnexal cysts by Dr. Levine and colleagues, many of whom are here this weekend. The SRU Consensus Conference update on follow-up and reporting. It is a great paper with some really nice, clear guidelines that kind of scale back a little bit, especially in the postmenopausal female, what needs to be followed and how often. And I'll let Dr. Levine really enlighten us tomorrow on that topic. I'm going to move on from that for now, but hopefully you can attend her talk tomorrow. Another normal structure, which we need to confidently call benign, is the corpus luteum. It's a normal finding in a premenopausal patient. It's what happens to the follicle once the ovum has been liberated. It's meant to release progesterone in anticipation of fertilization and potential pregnancy. These are typically small, 3 centimeters or less, with abundant peripheral flow and a thick wall. No follow-up needed for these typical corpus luteum. Some ancillary findings you may see are an endometrium in the secretory phase and potentially some free fluid in the pelvis related to recent ovulation. Feel comfortable with the appearance, of course, of a corpus luteum. We love the variant of the crenulated corpus luteum. This can be sort of a pitfall sometimes early on in your practice if you see this notching along the inner wall of a corpus luteum that has this crenulated appearance. It can give the appearance sometimes of little mural nodules, but this is another variant of the corpus luteum. You're catching it at a slightly different stage. The term crenulated really comes from a geologic sort of world. It describes that notched appearance that certain rock formations can take. And probably this is one of the best examples. It's a collapsing corpus luteum with a crenulated wall, but nice normal thick wall, peripheral color flow. The patient recently ovulated, was non-pregnant, did have some pain referred to that side, which is not atypical. So I'll get back to the point I made a few slides ago. I'd like you to consider avoiding the term, if you don't already, cysts for any normal ovarian structure. Remember that the ovary is really the only organ in the body with macroscopic cysts as part of its normal structure. The problem is that using the term cyst may lead to unnecessary follow-up imaging. I know we've all seen that happen. It can add anxiety to patients who read their reports. It can add expense, inconvenience, and not value. And I even would say, and Dr. Brown really taught me this early in my practice, even if you say simple cyst, normal ovary with cyst, or physiologic cyst. The term cyst is what's remembered by the patient and potentially a primary care provider. I've known a story like this personally where someone carried this diagnosis of cystic ovaries or cysts in the ovaries and really thought it was a pathologic condition. The perception by patients is that they're abnormal because of cysts. So if you have a 3-centimeter simple cyst, using sort of the radiologic use of that term, in the ovary of a premenopausal patient, just call it a follicle. The structure you see after ovulation is a corpus luteum, not a corpus luteal cyst. It's a suggestion that works well in our practice and potentially in yours. Hemorrhagic cyst, moving further down the review of benign lesions. This is when hemorrhage occurs within the corpus luteum or other follicle. These do resolve. This is a transient finding. It's when you see that reticular pattern of internal echoes within a cystic lesion that some would describe as the fishnet, the cobweb, the spider web, or the lace-like appearance. Some examples here. There should be no color flow internally, no solid vascular component. A variant, of course, is the retractile clot that looks solid appearing but has concave margins and no internal flow. Imagine a growing soft tissue nodule. You can't really figure a way that it could have concave margins if it was true tissue or malignancy. So feel reassured when you see those concave margins. Follow-up guidelines are based on reproductive age and size. The endometrioma, another variant of bleeding within a cystic ovarian lesion. Here we see more internal homogeneous ground glass or low-level internal echoes, as you can see in that top example. Endometrial implants on or in the ovary can lead to recurrent cyclical bleeding in a collection of old blood products that give this appearance. There should be no internal color Doppler flow. Sometimes we'll see multilocularity or tiny echogenic wall foci that can help distinguish from a hemorrhagic cyst if the echo pattern isn't clear. That's typical of endometrioma. These do not regress typically. We do follow them up at the initial identification to try to convince ourselves that this is not a hemorrhagic cyst masquerading as an endometrioma. Here's a case where we had an MRI correlate showing that bright, homogeneous T1 hyperintensity, a T2 dark appearance, and on a subtraction post-gadolinium, no internal enhancement. Malignant transformation of endometriomas does occur. It's quite rare. Higher risk patients are those who are older or have larger cysts. What you're looking for in these patients is a rapid growth of an endometrioma or development of a solid enhancing component. That's abnormal. Here's a nice case of bilateral endometriomas we see on ultrasound. Both have fairly similar appearing low-level homogeneous internal echoes. They're really tethered close to one another toward the midline. This is a transvaginal image at the midline. They have almost a kissing morphology. On T1, they're both very bright. I do admit they have varying ages of blood products in them. You can tell on the T2 weighted sequence. No internal enhancement, and they were both path-proven endometriomas. We see a nice laparoscopic correlate there. Moving on in our review of benign things, mature cystic teratomas, also known as dermoids, are a benign germ cell tumor. These can have focal or diffuse hyperechoic components. You're all familiar with their internal architecture, the dot dash sign or the lines and dots potentially reflecting a hair component. There really should be no central flow, but areas of shadowing are common. Malignant transformation, if it occurs, is of course very rare and is of the squamous variety. Also, older patients and larger cysts are more prone to malignant transformation. A lot of times, despite their being benign, they're removed for symptoms or to reduce risks of torsion. If they're not removed for whatever reason, follow-up is typically yearly to ensure stability. This case actually went to CT. I just thought it was an interesting multimodality case to show. It just really was too big for the ultrasound to feel really comfortable having looked at every part of the wall of this lesion. But that sort of low fluid component in it that was very homogeneous reflected this very, very low density sebum and fat. We had a fluid level and that dermoid plug there with a nice shadow. I'm going to spend just a moment on peritoneal inclusion cysts. We're outside of the ovary now, but this is a pitfall and can be confusing, I think. It's an extraovarian cystic lesion in the pelvis. Peritoneal inclusion cysts are not what we should call every extraovarian lesion. It happens in certain circumstances. So these occur when there's ovulation in the setting of pelvic adhesions. So think of a premenopausal patient who's still ovulating, who's had either prior surgery, PID, or endometriosis, any of which can contribute to pelvic adhesions. Your typical appearance is an ovary, which is normal appearing most of the time, at the edge of a cyst or suspended within fluid. The fluid, though, is not free-flowing throughout the pelvis. It's loculated. It's usually unilateral. You can see smooth, thin septations, some of which have flow, reflecting peritoneum itself. And these collections really do follow the contour of the adjacent pelvic organs rather than resulting in any sort of mass effect. They're benign and no follow-up is needed if they have a classic appearance and are asymptomatic. Here you can see the ovary on the left side sort of suspended in this, here's the ovary here, suspended in this cystic lesion, if you will, or loculated fluid. This was a large peritoneal inclusion cyst. Here's the correlate on CT with the ovary here. Follow-up is really by sort of the clinical presentation and symptoms. Here's another example. This was a 22-year-old female who'd had a right salpingo-oophorectomy and bilateral pelvic lymphadenectomy 2 years prior for a dysgerminoma. I like this case because it shows a hemorrhagic cyst in the suspended ovary with the peritoneal inclusion cyst around it. They can be quite large. So we're going to skip the gray zone and come back to it. I just want to move to the other end of the spectrum, which I know you're also all comfortable with, but those lesions that are worrisome for malignancy, internal soft tissue elements with detectable flow. So age, menopausal status, and cyst size really don't impact our recommendations for lesions with this appearance, but they are associated with the risk of neoplasm and malignancy. In other words, the older the postmenopausal patients, the larger lesions have increased risk of neoplasm and malignancy, but we don't feel reassured in a younger patient with a small suspicious lesion. They really the pathway of recommendation is the same. Here's a case of a mucinous carcinoma. This was in a 61-year-old female who presented with abdominal pain. It's predominantly a cystic lesion, but it has this large, irregular, eccentric, solid component with internal color flow. This was arising in a background of a mucinous borderline tumor. The uterus and the right ovary were negative. Another example here of a high-risk lesion, a highly worrisome lesion. This was a 48-year-old female, so younger. She presented also with abdominal pain. We have a predominantly cystic lesion with, again, an eccentric, clearly solid component with internal color flow, which was confirmed on spectral Doppler. This was a high-grade serous carcinoma. So we've gone through the benign and the highly worrisome or high suspicion for malignancy, and then we're back to our gray zone, as is what we'll wrap up with here. So there's a lot of sort of flavors of this. Those things that are suggestive of a benign lesion like a hemorrhagic cyst, but not classic. Sometimes these can be followed. Sometimes they'll go to MRI. We can have thin-walled cysts, but have a single thin septation or a focal calcification in the wall. That's the second point here. This really is based, the follow-up is just as a simple cyst would be, and we'll hear more about that tomorrow in the keynote. Multiple thin septations can be considered for surgical evaluation. This is suggestive of a neoplasm, but a benign neoplasm. And then we want to talk most about this sort of confusing sort of entity here is when we see a cystic lesion with a non-vascular nodule along the side and not really brightly hyperechoic like a calcification or a dermoid. So we'll talk more about that here. There was a paper in 2018 that looked at these types of lesions with an avascular internal component. We see them in both benign and malignant cystic lesions. This just isn't predictive enough to confer a strong suspicion of malignancy. If you're not getting flow in this small mural nodule, you don't definitely have a malignancy, although I agree it's something that needs more workup. In this study, they looked at 160 cysts with avascular internal components, and the majority of them were benign and non-neoplastic. The second largest group of these were benign neoplasm, and then about 7%, so not an insignificant number, were malignant neoplasms. Here's a few examples across the spectrum of indeterminate. something with a peripheral nodule without flow, something that looks like an endometrioma, but not totally classic because it has more hyperechoic foci in the center, not the periphery, and it's a little more heterogeneous. This was suggestive of a dermoid, but didn't have all the classic features. And then we had this lesion, which mostly looks simple and has a hyperechoic sort of focus at the periphery that really looks benign to us, but not definitely a wall calcification. So these are considered indeterminate. So MRI is helpful in select cases. It can potentially avoid surgical intervention for benign lesions. It has a very high negative predictive value when there is no enhancing solid tissue. If you do see a rapidly enhancing solid component on your MRI where it enhances more than myometrium, that's highly predictive of malignancy. So in the SRU guidelines, as I mentioned, sometimes MRI is recommended, sometimes it's considered an option versus surgical evaluation. MRI is favored when it's a simple cystic lesion, 7 centimeters or greater, in a young patient. The risk of a malignant lesion is less, and in ultrasound, we just might be limited by that lesion size and knowing and feeling confident in calling it simple. We'll hear more again about simple cysts tomorrow. The MRI option versus surgical evaluation in the 2010 SRU guidelines is those with at least 3 thin septations, a thick septation or nodule without flow, and those probably benign lesions that just don't have all the typical classic features. Please remember that MRI is not appropriate or necessary for a malignant appearing lesion. If you have thick vascular septations or a nodule or solid component with flow, those should go to gyn-onc, and unless they need it for preoperative planning, the MRI really won't add much. So what else do we know? We know that the SRU guidelines are effective for risk stratification. This was a study looking at 570 cysts. And using the SRU framework, the authors showed that that framework could effectively stratify risk of neoplasm and risk of malignancy in adnexal cysts with very low p-values when looking at non-neoplastic cysts from neoplasms and benign from malignant cysts. And in this group, they had mostly benign non-neoplastic cysts, because that's mostly what we see. Benign neoplasms, 13.5%, and they had a small number of malignant neoplasms, 3.2. So the SRU recommendation was a significant predictor of neoplasm and malignancy, even when controlling for patient age and cyst size. So feel comfortable applying these guidelines in this framework. I will note this interesting conclusion is that the recommendation of MRI when offered in those situations where MRI is an option would have reduced the number of surgical evaluations of benign cysts by almost 90%. So they went through and followed all these and had either path proof or imaging follow-up or clinical follow-up to say sort of what the outcome was. And then looking back, had MRI been pursued for some of these when it was an option, a lot fewer surgical evaluations would have occurred. So just briefly, I just have a couple minutes left here. This is a busy slide, but just to show you, if you have MRI versus surgical evaluation and you take the surgical evaluation approach, we do great. Very rarely are neoplastic lesions sent for no follow-up or called benign, so we're really good at that. Some benign neoplasms are seen in follow-up on ultrasound. For the MRI, so that, known malignant neoplasms would have gone to MRI under the surgically focused context. And here, under surgical evaluation, if that was recommended, still a minority of cases, 48%, were neoplastic. So a lot of benign, non-neoplastic lesions would have gone for surgical evaluation. And we'll just compare that briefly. Similar findings in the 1 and 2 categories. Whereas MRI would have imaged more benign lesions, less neoplastic lesions, and of the surgical group, when MRI is used, a much higher proportion of neoplastic lesions went down that path, avoiding intervention for benign lesions. I hope that makes sense. It's an interesting set of data. Surgical diagnoses were these. A lot of benign things did go to surgery under the surgically focused context. So just an example, a couple more of these indeterminate cases that I showed you. This one did end up being an endometrioma, which we thought it would be. This one did end up being a dermoid. It wasn't totally typical, though. So we had some fat then you could see on the MRI. It was symptomatic. They took it out. No malignancy there. This was just followed with ultrasound, this one with the tiny peripheral nodule, and we called it a probable cyst adenofibroma. This one actually went to resection. She was older, postmenopausal. This was serous borderline tumor in a cystadenoma. So we've seen some great cases today, crenulated corpus luteum and the peritoneal inclusion cyst, as well as others that you all are familiar with here, including the indeterminate cases. Stay tuned this weekend. We have the keynote address tomorrow, and a nice ORADS presentation will be part of one of the workshops on Saturday. So feel comfortable diagnosing normal and benign. Know that lesions with a vascular component go to gyn-onc. Our current ultrasound risk stratification guidelines are effective both with and without MRI, but MRI may have a role in reducing surgical intervention for the benign but sonographically indeterminate cysts. Thanks so much, everyone.